All right, up next we have Dr. Westermann talking about concomitant or stage tip arthroscopy with PAO. Does it matter?
All right, thanks, Ben, and thank you guys for putting this Chicago Hip Summit on. I'm happy to be a part of it. So I'll start with the case. This is a 35-year-old female. I think this is probably the patient we're sort of talking about in this first session. She has preserved motion. She has right hip pain, flexion 100, internal rotation 10, external 80, and positive provoking signs for joint pain. If you look at her hip more closely, lateral center edge is 20, which is sort of on the low end of the borderline measurement. Her tonus angle is 14, and she has a pretty stable fear index, actually, despite the higher tonus. A little bit of a head neck offset problem in the front. If you look at her AP, she actually has a little bit of an AP or mushroom-shaped hip, as Chris Larson describes it, at the 12 o'clock position, and kind of a mild anterolateral head neck offset morphology, and relatively low femoral anteversion for her level of borderline dysplasia. So what to do with this? Is this a scope patient? She's 35. Is this a PAO patient? Is it should you do a combined or staged, or just tell her to wait out a hip replacement, which is a great operation in somebody in her age group. So we elected to do a combined scope with a PAO. We refixed the labrum. This is the that 12 o'clock cam lesion, which is not really accessible through an anterior arthrotomy, but it's something that you can correct with a little bit of traction through a scope. So I think you can get a good comprehensive correction in the lateral and also anterior aspect of the head neck junction when you combine arthroscopy with PAO. And then a PAO in the same setting. She actually returned for her other side and is 2 years out with a good surgical result. So luckily we picked correctly in this patient. Another example of when you combine a PAO with a scope is this case. This is an 18-year-old dancer. She had a hip arthroscopy performed in Nebraska and was doing pretty poorly about 1 year out. She has classic dysplasia, lateral center edge of 12, diverging fear index. So this is a very unstable hip. Probably made the wrong decision during the initial treatment pattern in Nebraska. In a mild head neck offset morphology. And this is what we saw in the joint. So she had either a failed repair of her labrum with a big segmental defect. I'm not sure if this happened postoperatively or intraoperatively during her first scope, but as Jeff already pointed out, arthroscopies are not always benign. So in the setting of a revision case that's assigned a PAO, I think you should be ready to have a graft and to be ready to do the best job you can at restoring the chondrolabral junction in combination with a PAO, especially given a young patient, age of 18, a lot of years to live on a hip like this. So this is a case where she had a segmental labral reconstruction, as you can see here. I'm not sure if it's showing up well with the glare. And then a PAO to normalize her lateral coverage and balancing nicely that Mike did between the anterior and posterior walls here. Also, she has this kind of, I don't know if we call this a cam. Dr. Clohissy, taught me it's more of a lack of head neck offset. It's kind of mild in her case, but we did do a concomitant osteochondroplasty to prevent secondary impingement here, and we found that if this is not done in the setting of PAO, then you're at risk for increasing your joint contact stresses. So lack of internal rotation, the presence of lack of head neck offset, especially in the anterolateral head neck junction. You want to protect the results of your PAO by performing a head neck osteochondroplasty at the same time. What about other areas of secondary impingement? So if you have somebody with a low anterior wall index or low acetabular coverage, such as this case, I think Mike will present this one later, if you're increasing your anterior coverage, you're going to bring your anterior inferior iliac spine lower, and especially in the cases of low femoral anteversion, our preference is to do this through the scope, because you don't have to take down the rectus or split the rectus from the top if you're doing a subspine decompression open. So another way to avoid secondary impingement if you're increasing your anterior coverage during PAO is to use the scope to decompress the anterior inferior iliac spine. This paper's been brought up 3 or 4 times already, but one of the issues that I had when Paul Boulay and John closely asked us to enroll patients was that every patient that was indicated for a PAO in the study was randomly assigned scope or no scope. So it would be hard for somebody with a normal labrum on their MRI and no correctable bony morphology such as subspine or head neck offset to correct. It would be hard to justify adding a scope to that patient population when I wouldn't feel that would be indicated or needed. So every patient was indicated for PAO, randomized to scope or no scope. 60% had repair, 7% had debridement, and 33% had no treatment during the arthroscopy. And they basically had similar outcomes as has been discussed. So probably not every PAO patient needs a scope, and it should be driven by other factors such as revision or bony morphology correction or significant chondrolabral junction dysfunction. I was assigned this talk about staged or combined. I've only done this combined with Mike Willey. The surgical decision making for staged or combined, I think it greatly relies on the availability of surgeons, and that's kind of what Giordano recognized in his study. They looked at 39 combined scope PAOs, compared these to 23 staged cases. The 23 staged cases had a scope done in an ASC, and 3 weeks later they had an inpatient PAO done with hospitalization for recovery. They found that the staged patients, so the patients that went to the ASC for the scope, had actually shorter operative time when you combine the ASC operative time with the hospital anesthesia time at 5 hours compared to 6 hours when it was combined. And similar outcomes were found here. I could not tell, I was discussing this paper with Mike, I could not tell if they adjusted their modified Harris hip score, but they had both groups had 71 for the average modified Harris hip score at their final follow-up, which is probably lower than some of the other PAO studies out of WashU and others. So in conclusion, I think hip arthroscopy is an important tool in treating borderline hip dysplasia and some cases of DDH, but not every case needs a scope. We strongly consider adding a hip arthroscopy with patients with a previous scope, AP cam morphology that would not be accessible through an arthrotomy, or AIS deformities when you're increasing your anterior coverage and creating secondary extra-articular impingement. Combined, I think the same day, the same surgical setting is much better for the patient, so that's what I would recommend if you can fit that into your practice. I think it'd be it's terribly or twice as inconvenient to have 2 procedures done from a patient's perspective. On the other hand, it's more convenient for surgeons to do it in a staged fashion, especially if different people are doing the scope and the PAO. And you do have some literature to suggest that incomes are non-inferior when done in a staged manner. So thanks for your time.
Thank you. And up next, we have Dr. Harris talking about some soft tissue factors in the role of borderline dysplasia.